we're going to have Jeff Tosoian come back to speak to us. He's assistant professor of urology at Vanderbilt. We've got a lot of Vanderbilt ties here. And he's the director of translational research, division of urologic oncology at Vanderbilt. And he's going to talk about race-based differences in prostate cancer biology, implications for diagnostic testing. Come on back.
Thank you so much, Mady. As mentioned, I'm Jeff Tosoian. I did my oncology fellowship here from 2018 to 2021. And I've since gone to Vanderbilt, where we're helping to build some translational cancer research, and fortunate enough to have partners in practice like Nicole Miller, who's making her first visit to Ann Arbor right now, and Amy Luckenbaugh, who I know you all know very well and is just a phenomenal surgeon and colleague. Thank you very much for the opportunity to speak. This is an important topic, and it's exciting to be able to talk about it with Dr. Powell here, who's truly a pioneer of this space. And so, with no further ado, these are my disclosures, none of which are particularly relevant. And so here are the data in the United States showing prostate cancer incidence by race. And as we can see, incidence of prostate cancer is highest among Black men by a rather notable margin. When we look at mortality, we see a similar trend. Again, Black men are disproportionately adversely affected by this disease. And so this is a problem. Ultimately, Black men are 1.8 times more likely to be diagnosed with prostate cancer, 2.1 times more likely to die of prostate cancer. And so there have been many conceptual models set forth to help explain why this may be the case. This is one from my good friend and colleague Yao Nyami at the University of Washington that really focuses on the structural and social determinants of health, which undoubtedly have a great impact on the observed disparities. Here's a second published framework that incorporates environmental stressors, lifestyle, as well as treatment, and the potential role of genetic predisposition on increased incidence and inferior outcomes of prostate cancer. And so today I want to briefly talk about the role of differing tumor biology and how that may be a mediating factor in what's observed clinically and what we can and are doing to help address these things. And so we'll ask a few questions, starting with what do we know about race and prostate cancer tumor mutations? And I make that point, tumor mutations, only to emphasize, and we'll review here, we're talking about the mutations of the tumor itself. So when we think of our DNA or potential mutations, there's, of course, germline DNA found in all of our cells, inherited from our parents, that predispose to cancer risk. Also, somatic changes or somatic mutations, these are the ones that are found only in a limited area, particularly within tumors, and often due to environmental factors, and can provide an actionable target for therapy. And so we're talking about tumor changes here, and it's important to acknowledge that all of us knowing race to be a social construct, how is it that we observe these differences in the tumors? And that gets back to just pointing out that race is, of course, a poor proxy for genetic diversity in our germline DNA. But our tumor genome, our tumor transcriptome, is in fact a product of multiple factors, and that spans social, environmental, and biologic factors. And this is, in fact, a figure from one of Dr. Powell's publications that shows how these various factors all contribute to the tumor transcriptome. And so we'll look first at some data from Scott Tomlins, who's here at Michigan, and Felix Fang in 2015, looking at different molecular subtypes of prostate cancer. And before I lose everyone when we start talking about subtypes, we can think of this in a very straightforward way. I implicitly promised Lindsay Harrell that my talks will not include heat maps. So we're keeping it simple, but this is really just, a simplified version of what we're talking about. But the fact is that there are many ways to get to prostate cancer, many roads to prostate cancer. And so when we talk about subtypes, you can think of it as just there's a given mutation A, that can lead to prostate cancer, and that prostate cancer we'll call subtype A. There are other mutations, mutation B in this case, we'll call that subtype B, and so on and so forth. And so Scott and the group found really 3 mutually exclusive mutations that would lead to prostate cancer, and from that developed 4 mutually exclusive groups. The first 3 based on those specific mutations, and the 4th was just based on the absence of any of those 3 mutations. And they also found that the most prevalent of those, the ERG-positive subtype, is 2 times more common in white men. SPINK1 positive subtype is in fact 5 times more common in black men. And so validating these findings was some work that we did when I was a resident. And here again, you can just see European American, African American prevalence of these various subtypes. You see approximately 2-fold differences in each of these. Additionally, again, in another cohort, the ERG-positive subtype, twice as prevalent in European Americans, P10 deletion, twice as common in European American or white men as compared to black men. The group from Cornell published similar findings, again, 2 to 3-fold differences in these mutations that lead to or contribute to the development and or aggressiveness of prostate cancer. And so I think we can take as a matter of fact at this point that these different subtypes of prostate cancer exist, and the data certainly indicate that they appear to differ in prevalence between white men and black men. And so then the question is, why does this matter? And using that same simple model, I'll point out that the evidence of these subtypes is what is expressed, and these factors are now what we measure in blood, urine, and tissue as part of our diagnostic, prognostic, or predictive clinical tools. And so ultimately, the expression of these various subtypes are what drive our diagnostic testing, our prognostic testing, that of course leads to treatment selection, the development of targeted therapies, and for each patient, the selection of targeted therapies. And so the concern is that as these molecular markers are increasingly integrated into clinical practice, by not accounting for these differences in tumor biology across race, we could in fact be introducing new or propagating existing racial disparities. And so for a very simple example of that, of course, if a marker of cancer is less prevalent in black men, then the use of that marker for detection of cancer is going to be less effective in the black population. And this, really hit home in some of the work we've done over the last few years, looking at the original My Prostate Score test just incorporates 2 molecular markers to detect for early detection of prostate cancer. And certainly a limited sample size, but when we looked at those data, indeed, we found that this test performed not as well in black men relative to white men. You see at a similar sensitivity, about a 15% reduction in specificity in the black population. And so, this made this a very obvious area of need to me, and it's something that, we'll continue to work to address. Across the literature, really we now have more than a decade of evidence showing variation in these different molecular drivers of cancer, that showing variation between the Black population and the white population. And as I've mentioned, right, why this matters is, as shown here, Black men might not respond as well to certain targeted therapies given a reduced instance of PTEN deletion. Several more examples. Black men might have alternative mechanisms to confer aggressiveness, which is to some extent debatable, but certainly to therapeutic resistance and targeted therapy options. And so ultimately it matters because our tumor biology is linked at really every phase of clinical practice to what we do to manage and treat our patients. And failing to acknowledge these differences, again, threatens to introduce disparities. And so what are we doing about it? I have to acknowledge my good friend Yao Nyami at Washington says a patient-centered and community-engaged approach is our key to creating equity in the care we deliver and outcomes we achieve. And following on that, he has set up what's called Backpack, a collaborative for prostate cancer action among Black men and those of African descent. I was able to join their group in Seattle earlier this month, and there really is a focus on involving the patients, the community, in research. We had several focus groups where the patients were generating research ideas that were important to them. And the effect of this is really apparent in some of their early work. I'll give as one example, they sent out a survey to patients, 2,200 patients, and actually had an 80% response rate. I don't personally do a lot of survey work, but I think 80% is pretty darn impressive. And so that will, reflect the importance of empowering patients to be a part of the work that we're doing. This fellow might look familiar. This is a slide borrowed from SIMPA talking about how to truly understand these biologic differences. We need to control for or ensure equal access to non-biologic factors. And so that is, certainly part of the answer to addressing this problem. In terms of the work I'm doing largely in biomarker development and validation, we need to ensure that this is being done in diverse and representative cohorts. For our part, this is one of our grants, and just showing that, based on what we learned from the prior test, our entire second aim is ensuring that the test that we've worked to develop will perform as well in African American men. And, if it does not, we have plans to ensure that a test that does serve African American men as well is developed and validated. And so part of what I've been doing in Nashville is establishing partnerships with Meharry, Tennessee State University, and our Nashville VA to ensure that our work is representative of the patients who stand to benefit most from it. And so I'll very briefly mention the analytic approaches. Of course, the validated model we will evaluate in the African American population. Depending on its performance, we may then develop and validate a separate model in the Black population, or really this third approach is the one I'm most excited about and I think is most promising, and that is to develop a subtype-informed testing model to account for these race-based differences, and that would be through leveraging that most prevalent mutation, the ERG mutation. We know that in the setting of ERG positivity, there are certain markers that contribute to detection more so in patients that are ERG positive, and then a separate set of markers that are more important in those patients that are ERG negative. And so we are looking at some early data and likely planning to develop a test in which ERG status can be that first question asked, and then from there, the optimal test is used to ensure the patient is getting really the most personalized diagnostic testing in this case for them. And so in conclusion, of course, ensuring equal access to quality healthcare is absolutely vital in addressing these disparities, but there's good evidence that it may not eliminate disparities altogether. We now know that these differences in subtypes of prostate cancer exist across race, and as we use molecular markers clinically more and more often, we need to ensure that we're acknowledging and addressing these race-associated differences in tumors. Ultimately, we have to proactively address these findings, particularly in the Black population that is at the highest risk of harm from prostate cancer. Really appreciate all of you. Thank you so much for your time.
We have a couple minutes for questions.
Hi, excuse me, I'd just like to make a comment to expand on your research, is that as the more we get into the scientific discussion of race, the term race becomes meaningless, and the color of skin also becomes meaningless. What it is involving is ancestral geographic origin. In fact, in West Africa, the incidence of prostate cancer is significantly higher there than here, and in the Caribbean, Jamaica and specifically Haiti, it's higher than here. However, in East Africa, it's a very low incidence of prostate cancer. Same color, but different parts of the country, and it relates to the environment. So just to keep that in mind, and even in Europe, in Northern Europe, prostate cancer is greater than Southern Europe, and it's been reported that the gene pool is different in Northern Europe as opposed to Southern Europe. So keep those things in mind as you go forward with your research.
Absolutely. Thank you. And yes, one thing we have discussed often is that really it's not race itself that is, associated with these things, though race appears to be a surrogate for whatever these underlying factors are, as you alluded to, the environment, stressors. And so absolutely, that's a critical point. Appreciate it. Awesome. Thanks, y'all.